Welcome everyone to today's webinar. I am Erin Deach with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Dr. Kevin M. Odlin is the co-director at the Endometriosis Center and Advanced Endoscopy Fellowship at Mercy Medical Center in Baltimore, Maryland. He is also a clinical instructor in the Department of Obstetrics and Gynecology at the University of Maryland School of Medicine. Dr. Odlin completed his OB/GYN training at the University of Maryland School of Medicine, in addition to completing a fellowship at Mercy Medical Center focusing on advanced laparoscopy and pelvic surgery. He is board certified by the American Board of Obstetrics and Gynecology. Dr. Odlin is focused primarily on the diagnosis and treatment of complex pelvic surgery, endometriosis, and fibroid disorders. Dr. Odlin, I'll now turn the floor over to you.
Great, thank you. Thank you very much. Thank you for everyone for taking out your busy day and come joining us. I think we have a pretty exciting topic here. Talking about the topic is called Human Lives and Robotic Money, but the question really is, how can we take care of patients as good as we can? Which patients are an appropriate candidate for robotic surgery? Which patients are appropriate candidates for non-robotic surgery? And how can we optimize the patient's care while keeping it cost neutral at all possible? So thank you for joining us. Okay. So learning points. I want to just kind of go over what I hope to talk to you about, and this is it in a nutshell. We want to talk about how we can angle our surgeons to become low-cost, high-value providers. We want to talk about lower-cost techniques. At this point, we know that robotics is a good process by which we can manage advanced patient needs, but we know that it's also more expensive in the majority of situations. Hopefully, we'll all agree at the end that the Olympus 3D system is quite helpful in continuing to provide the improved care, but also providing less cost structure. I'm from the East Coast, Maryland specifically. Value-based payments are a huge part of our horizon. At this point, we're already into systems where we are being given color coding through our physicians as in a low, moderate, or high-cost provider. Facilities are being reimbursed based off of their procedure costs, and it is an incredibly competitive environment we're in right here, and I think the country in general is going to be that way very, very soon if you're already not in that situation. Also, the bottom picture shows that to the left we have the United States, and we were a very regional referral center for advanced laparoscopy and endometriosis, and since the 3D system and the marketing that we've done with it, I've continued to get patients throughout the whole entire country, the majority of which are the East Coast, but we have absolutely branched out to the middle part of the country and recently out west. So I don't see how this isn't going to be a situation that we can help all hospitals provide. I want to talk about how we went from the regional facility that we talked about to a very high volume, highly sought out national competitor. And the question here is, why do we really care about increased costs? I mean, the reality is that the old system, cost didn't matter as much. You and I know that as we did cases, the cost got pushed on to the insurance companies, sometimes pushed slightly on to the patients, but the majority of times everything was a push through. If it cost more, we charged more, and in the end, we got reimbursed more. But in today's system, especially here in Maryland, we're bundling, we're grouping costs. We now have hospital costs, combined with anesthesia costs, combined with surgeon costs, and as the surgeon spends more, the profit margin shrinks, and here we're trying to figure out how do we manage that. At this point, It has been pushed entirely onto the surgeons, but the talk is that in the next few years, as we start to refine the system, more and more, very likely, if the surgeon needs to spend more money, then that's going to come out of their bottom line. Not so for the hospital, and clearly not so for anesthesia. So it becomes more and more of an issue where, as a surgeon, I need to hone my costs while maintaining my surgical skills and keeping the whole process so that the quality is the same. Because ultimately, in the long run, with the new Medicare systems, quality indicators are very important. Back in 2009, when Obamacare was kind of prepping us for the whole entire Obamacare system, he made a speech that was at the AMA conference, and I think this is very telling. He said basically we spend over $2 trillion a year on health care, more than 50% more than the next most costly nation. The cost of our health care is a threat to our economy, and I think this year's election process bore that out more than he could even tell. Both the Democrat and the Republican Party were both talking about reform to Obamacare. But the reality is that reform costs. It probably means the exact opposite. We have to bring Obamacare down. We have to bring our health care costs down significantly. And this is fiscal year 2015. This is something that came from the U.S. government spending website. It is something that you and I, or all of us, can identify. And you can see from this pie chart that the largest portion of the pie is going to health care. And as long as that continues to be the case, we are going to continue to spiral out of control with our deficit. And we, at some point, we're going to reach the point where we will be unable to manage our healthcare spending. So the pressure is going to get more and more upon us as a provider, upon the hospitals, ancillary spending on imaging, medications. These are all things that at this point aren't controlled anywhere near as they need to be. So that being said, we're looking down on the procedures that were done in 2010, and they essentially are the exact same right now. One of the reasons why I outlined hysterectomy is because as a gynecologic surgeon, this is the one thing that I can control the most. And 500,000 or so hysterectomies are done every year. So at this point, each one has a certain cost associated with it. And as we have downward pressure from the government to decrease costs, these are the kind of procedures that we're going to look at. I know high-cost procedures like hip replacements, knee replacements, hysterectomies, angioplasties. These are all things where they're capping. They're sitting here saying, "This is exactly what we're going to pay. You guys figure out, how you're going to make it work for your hospital." So we absolutely need to come up with a plan that we can control the cost, but also continue quality care. And this is a slide that I think kind of breaks down the process that we're talking about into a nutshell. When do I use robotics? When do I use traditional laparoscopy? How can I do things safely? And in the process, how can we decrease cost? For those who use the robotic system, are not clinicians, there are absolute advantages to robotics versus traditional laparoscopy, versus open surgery, versus vaginal surgery in our chosen field. But the highest overview is just this. There is magnified vision. You get three-dimensional, high-definition visualization, allows you to see depth, allows you to see crystal imaging, which is very, very difficult to get without some sort of high-definition laparoscopy. Traditionally, over the last 10 years or so, the only way to get three-dimensional visualization was robotically. Ergonomically, the robot allows you to not have the strain of the back and the shoulder that you traditionally get from laparoscopy. As the surgeons get older, their fatigue gets faster, their stamina is less, their complication rates go up, partly because of fatigue, carpal tunnel, all these things that go along with traditional laparoscopy. Since you're sitting at a console, like this surgeon is here, with your wrists resting on this arm board, in your more ergonomic position, looking down through this eye area, visual field area, that you don't have that fatigue. So that is an advantage. The biggest take-home point that allowed many non-laparoscopic surgeons to become robotic surgeons was wristing of instrumentation. 7 degrees of freedom. You're allowed to have greater than 90 degrees of articulation in 7 different motions. So you're really mimicking that of a normal wrist throwing situation, so that you could reproduce a suture technique that you couldn't reproduce laparoscopically, since most laparoscopy is what we call straight stick without any sort of wristing at all. Motion scaling, tremor reduction is important. You're allowed to go 1-to-1, 1.5-to-1, 2-to-1, so that I can move very large distances to get smaller movements of the robot. It allows more precise dissection. It allows more precise movement. Tremor reduction is as it mentioned, so that you get rid of the fine motor tremors that some people might have in the case that they were doing. So these are all huge advantages over traditional non-3D laparoscopy, over open surgery and/or vaginal surgery. And that honestly is why it was so popular. It allowed a surgeon that couldn't give a patient a minimally invasive approach, a minimally invasive option. You went to the general OB/GYN for routine surgery, and if you wanted an in-and-out surgery, a laparoscopy surgery, they had to refer to someone else. In this situation, the majority of the surgeries they could keep to themselves, not have to refer out, and continue with the care of the patient, which financially is to their advantage. So you went from an open surgeon to a laparoscopist, which traditionally has been the purview of the minimally invasive specialists, the fellowship-trained doctors that could do the complex surgery that the other doctors couldn't. So the AAGL, which is the American Association of Gynecologic Laparoscopists, as well as ACOG, the American Association of Obstetricians and Gynecologists, initially they embraced robotic surgery without fettering. They knew that it was a huge advantage that doctors that were doing open surgery now could do minimally invasive surgery. But over time, they, through studies, and were able to show that it isn't the panacea that the robotic company, Intuitive, thought it was. It wasn't the improvement over laparoscopy, that at best it was essentially the same as laparoscopy. So the AAGL position on robotic to conventional laparoscopy showed that essentially for benign surgery, they are comparable techniques. There is no improvement of one over another. There isn't an advantage for robotic versus traditional laparoscopy as long as the surgeon doing the surgery felt comfortable doing both. There was not improvement in perioperative outcomes. There was not an improvement in intraoperative complications. Length of hospital stay was essentially the same. Conversion to open surgery was essentially the same. So they wanted to make sure that people's statements were accurate, that they weren't touting one, because traditionally the robotic team was saying that this is the best thing out there. There wasn't any improvement medically for anything other than robotics, and if you wanted to be the best surgeon in the area, you were a robotic surgeon. So they just reiterated similar longer operating times. I know in my facility we worked very hard to get turnover times low with robotics, but the majority of the studies show that there is a lengthening of procedure time, usually 30 to 45 minutes. In my experience, there definitely is turnover time increase, whereas the surgery itself generally is probably about the same. Higher associated costs is clear. There's virtually no doubt that costs are increased whether you include the sunk cost of the robot or you don't. So the data is clear that at best it's similar, and at worst it costs more with longer OR times. These are the areas that most hospitals are starting to look at as the appropriate indications for robotics. It is clear that GYN malignancy, cervical cancers, uterine cancers, early stage ovarian cancers, these are areas that the robotic system is able to provide a quality care benefit. You can get better magnification of lymph nodes, so you can get larger lymph node chains. They have something called Firefly that allows you to identify the lymph node mapping so that you're making sure that you get the sentinel lymph nodes and any lymph nodes that may be involved. But in general, outside of GYN oncology malignancy surgery, ladies that have a BMI of greater than 40, uteri that are greater than 250 grams, patients with multiple previous laparoscopic surgeries, minimally invasive myomectomies. Myomectomies are fibroid removal surgeries, and abdominal sacrocolpopexies, which is the abdominal mesh surgery where you're taking the vagina and tacking it to the sacrum. So the common thread here is suturing. Myomectomies and colpopexies are highly suture intensive. Suturing is good for wristing. BMI of greater than 40. The fatigue of surgery is partly due to the resistance of the abdominal wall. Using the robot, there's no resistance with the abdominal wall. Uteri greater than 250 grams, it's just bigger uteri require better magnification and three-dimensional vision. Of note, all these indications actually were for traditional two-dimensional laparoscopy versus robotics. It was not in coordination with the 3D system, and I would argue that all of these indications are identical robotically versus the Olympus 3D system because the majority of these issues are associated with better visualization, better depth, better clarity, and they are essentially equal amongst robotics and the 3D system with Olympus. This is right here is getting into the nuts and the bolts. We talk about cost, we talk about quality. We've already identified through the AGL position that quality is essentially the same amongst robotic and laparoscopy. This is a peer-reviewed journal, the New England Journal of Medicine, and its data was pretty substantial, saying that each robotic case, on average, was $1,600 compared to a comparable traditional non-robotic laparoscopic case. That is only if you're talking about the actual cost per case. If you're adding in the amortization of the cost of the robotic system, the cost doubles. I would argue that's probably not an accurate number for multiple reasons. Obviously, the more volume you do, the lower that amortized cost would be. The less volume you do, the higher it would be, because cost per case of a $2.5 million robot clearly varies based on how many robotic cases you do. Most robotic doctors talk about that as a sunk cost, which it clearly is, but it's a sunk cost after you spent it. You had to spend it in the first place. And this is directly at my hospital. This is actually my cases. I do both. I'm a robotic doctor as well as a laparoscopic doctor. I have 3 block OR days per week. I see patients in the office 2 days. I operate 3 days a week. I have 3 robot block days per month. The rest are all non-robotic block days. So I do roughly 12 to 15 robotic cases a month. I do, on average, 50 to 55 total cases per month. So I'm not a person that only does one versus the other. I do both. I tend to do larger uteri, colpopexies, and myomectomies robotically. And these are my costs right here. So direct supply costs for robotic cases at my hospital, Mercy Medical Center, including an air seal system. An air seal system is essentially a insufflation system that allows more variable intra-abdominal pressure. It allows me to do my cases with a lower intra-abdominal pressure, less venous return complications, less difficulty with anesthesia providing their care, and it allows me to use greater Trendelenburg with larger patients. So the initial cost of the system is there, but this is only the actual increase of $150 per case for the insufflation tubing. So it didn't include the cost of the system. But direct supply costs are $1,424. If you do a 3-arm case versus a 4-arm case versus a 5-arm case, that clearly is a difference in cost. On average, most arms are $250 per use. They range from $180 per use for a monopolar hook to over $300 per use for some of the more advanced devices. Now, if we're talking about a suturing device or a stapling device, like the appendiceal stapler, then you're talking about more than $500 per per case. But in general, just the straightforward traditional hysterectomy or non-bowel procedure costs are here. I traditionally do mostly 3-arm cases plus the cost, so my traditional cost is around $2,254 per case. This is the robotics costs. The TLH cost is $1,510, still using the same air seal system with the 3-dimensional tower and a Thunderbeat handpiece for energy. So everything else, like suturing devices, my suture cut needle drivers that I have to use for the robot, they're traditional laparoscopy that are reusable instruments. They're not disposables. So the cost per case is significantly lower. So at my hospital, this is real-world numbers. Each of my robotic versus traditional straight-stick hysterectomies saved the hospital between $745 and $1,245 or $1,244 based off of whether you're comparing a 5-port or a 5-arm robot or a 3-arm robot to the traditional 3-port TLH. So there's a significant cost savings there. In my experience, in my hands, I post my traditional laparoscopy as an 1.5-hour procedure, and I post my robotic cases either an 1.5-hour or a 2-hour case, basically depending on whether it's a larger patient, larger fibroid. So there is a little bit more variability. I would say that there isn't a difference in speed. I don't believe either is faster or slower. My blood loss is the same. Both patients, be it traditional laparoscopy or robotics, go home within 2 hours after surgery. Knock on wood, I've been lucky that at no point in my career have I ever had a bounce back of a patient for being sent home that came back with a complication like bleeding or bowel injury, or I've had a very few vaginal cuff dehiscences, which is, I think, a cost of doing business, especially with a high volume surgery practice. The vaginal cuff dehiscence rate is well below the accepted standard of 2%. I've probably had 3 in the last 500 cases that I can remember. So be it robotic or traditional laparoscopy, neither of them is safer, but we clearly know one of which is more cost effective. And this is a system right here that Maryland has put together, Blue Cross and Blue Shield of Maryland, of the Mid-Atlantic, has created a pilot program about 4 or 5 years ago, and they wanted to incentivize their primary care physicians to share the cost of care. And their thought process was, they create a patient care home. Basically, each group of 4 to 5 doctors takes care of a panel of patients, and all of those doctors are tasked at decreasing costs. And if that grouping is allowed or able to decrease cost, then Blue Cross is willing to kick back some of the cost savings to the doctors. So there's a financial incentive for those doctors to decrease costs. And the ways that they were kind of coached as to do so is keep their office hours open longer so that they would decrease ER visits. You know, if you've got a 7 o'clock patient calling with shortness of breath or chest pain or complications similar to that, and there's no one in the office, you don't feel comfortable saying wait till tomorrow. You would say go to the ER. So evening hours are encouraged. Saturday morning hours are encouraged. You're cutting down the window for them to go to the ER or the urgent care, because we all know that those things are more expensive than a quick level 3 office visit with a little bit of blood work or maybe an EKG. They also encourage generic medications versus obviously the branded medications that are significantly more expensive. Imaging studies, MRIs, you know, the cardiac imaging, the vascular studies. These are all high cost imaging studies. Their goal was to cut back on those and increase ultrasounds, Doppler studies, things that are not anywhere near as expensive. And the last bullet point is the one that matters the most to me: refer to the lower cost surgeons for procedures. And Blue Cross Blue Shield has a website that each primary care can log into, punch in a field of expertise with a mile range, and they're going to punch up all gynecologists in a 10-mile range. They're going to show who's a blue a green doctor, a yellow doctor, or a red doctor. Red doctor is most expensive, green doctor is least expensive. The more red doctors you prescribe to or refer to, the higher that your panel's costs are going to be, and the less likelihood of you being able to get your bonus at the end of the year. Their goal was to get 3% decrease in cost over 3 years. The first 3 years of this pilot program, they had 3% decrease in cost every year. These primary cares were motivated because they were reaping a financial incentive. So when I talk to docs in the area about this, I talk to them about saying that their referral docs are going to break their referral pattern to refer to me because I'm a cheaper option. So another example of that is my hospital. Mercy Medical Center is a very high volume community hospital, small, 150 beds, not terribly small, but 150 beds, but we have 30 ORs. We have 5 or 6 orthopedic ORs that run till midnight. We have, more than 20 ORs that are doing non-orthopedic surgery, a lot of laparoscopy, and the bottom line is that we're a mile away from University of Maryland, we're a mile away from Johns Hopkins, and we completely crush them in our surgical volume because, speaking for hysterectomies, the average cost for hysterectomy at University of Maryland and Johns Hopkins are $23,000 and $25,000 respectively. At Mercy Medical Center, it's $15,000. So in the state of Maryland, Blue Cross Blue Shield has identified us as the blue ribbon provider for women's care. Their goal is to push their patients to us. Even if you're an out-of-network patient that has a 10, 20, 30% copay, the math adds up to come to Mercy because the $10,000 or the 40% cost savings in the case is going to work out for you as well as Blue Cross. And our surgical volumes have gone through the roof as we've gotten better at taking care of our patients. Greater than 95% of my patients go home the same day. Very rarely do I have a hysterectomy patient that spends the night in the hospital. These are things that don't happen in academic centers or traditional centers that don't feel as comfortable about their techniques and their instruments. This is a very similar system. Maryland is a different system than most of the country. We basically have a deal with the federal government that says if we keep our cost containment of health care to less than the inflation rate, less than 2%, then they guarantee fixed they guarantee fixed payments to the hospital. So it's completely to the advantage of the hospital to keep costs down so that they can guarantee at the end of the year how much money they're going to make because they know the amount of surgeries they do on average and the amount of costs they have on average and the amount of payment they have on average. So at this point, Maryland has created a situation where it's a 3-year revolving window, and your average surgical costs, your average reimbursement, and your average caseload is what you're allowed to be given for that given year. So basically, if Mercy's cap is 1,100 procedures, then that's the amount of procedures they can do. Anything above that's not going to be paid for. If you have $100 million in surgical revenue, that's the amount of money you have. So it is to your advantage to increase the amount of high-quality cases at the lowest cost so that you can have the widest spread between actual case costs and the amount of allotted dollars from the hospital. This is very likely a system that the country is going to go to because CMS is using us as a pilot program. If you look here, you can look this up on Maryland website. You'll see a much more in-depth explanation of how the process works, the HSCRC. So as you use the robot, it will cost you more. This is just where I see the platform, robotics on the right, very complex, very expensive, 2D laparoscopy, a minimalist approach, good for things that are low acuity procedures that don't need the significant definition and depth that you would require with either of the 3D systems. A little bit on the Olympus Endo Eye system itself. It's a 10mm camera. It has greater than 90 degrees deflection. so that you're able to see areas of the pelvis or areas of the abdomen that you wouldn't otherwise see very well. The areas that it works the best and has the highest interest is bariatrics, gynecology, surgical oncology, GYN oncology, general surgery, colorectal surgery, things where you require a lot of suturing and a lot of changing of visual angle. One of the deficits of the robot is you either have a 0-degree scope or a 30-degree scope, and it's either 30 up or 30 down. The 3D system here, it's flexible in any visual field. You have 100 degrees of deflection in 360 degrees of a horizontal plane. This is a bench study that was done at Vanderbilt with their general surgical fellowship in MIS. They wanted to see, was there improvements with the 3D system versus the 2D system? And the data is clear. The people that were used to doing traditional two-dimensional laparoscopy, when they moved to three-dimensional systems, they got faster at doing things. They were faster suturers. They were faster graspers. They had less grasping errors. They weren't grasping past products or not grasping deep enough. And then, suturing time was improved. And these are things that make perfect sense, and Intuitive had been touting for years prior. It's the same exact response that they got. It's just, a less cost-intensive process. These are things that the Fellowship Council has kind of put out there. How do we improve laparoscopic skills? In the GYN world, the robot, the person who's on the robotic console, is the one doing the surgery. So anyone that's at the bedside isn't effectively learning. So as the attending, the traditional system is attending on one side, the resident or fellow on the other, and I do one side and they do a side. So they mimic what I do. I'm able to stop them if I feel they're not in the right plane. So you feel much more comfortable with traditional laparoscopy training. The problem is with the robot, if you have one console and one person on that console, I'm going to have a very hard time stopping a resident before they do something potentially dangerous, like burning bowel by stepping on the wrong foot pedal so that they touch monopolar versus bipolar, or they grasp something they shouldn't grasp, or they throw a suture through the wrong spot. So what we're finding is laparoscopic training is diminishing because there's less people doing traditional laparoscopy, and also they are not allowing the residents or fellows to do much robotic surgery. So they're not only walking out less qualified training for traditional laparoscopy, but they're actually not trained robotically. What Intuitive is finding they have to do is they have to train these people once they get to the hospital, because unless you've done a fellowship, you're not going to come out with the appropriate amount of cases to become robotically trained. So these are our issues. We are finding that the majority of people are unable to manipulate tissue atraumatically. They can't identify anatomic planes. They're not able to suture well. They are clearly not trained well in advanced laparoscopy. So we need to get better at figuring this out. The 3D instrumentation is just that perfect melding of the robotic experience with traditional laparoscopy experience. I'm able to be at the bedside. I'm able to train my residents and my fellows by the same traditional old school training process. I'm on the left, they're on the right. They're getting all the advantages of three-dimensional imagery. They're seeing tissue planes better. They're seeing anatomy better. They're able to suture better. It's not as easy as robotics because there's not wristing, but you're able to identify angulations of the suture, angles of tissue, so that you can better adjust your suturing technique as compared to a 2D system. Just kind of an overview here. I think I'll only talk about just a few really important things. Robotics has no tactile feedback. You are unable to identify tension unless you visually see it. So in very difficult areas like the rectovaginal space, the periaortic lymph nodes around the aorta, dissection around the ureter as it's implanting into the bladder, these are things that are very delicate. And robotically, you're training your eyes to help you get tactile feedback. And traditionally, this is the area where you have the largest amount of complication, and that's why the robotic learning curve is high. These are issues. Visual field, like we talked about, only a 0 or 30-degree angle. As hospital administrators, Robotics is a large system. It's minimally mobile. It's in a room. It doesn't leave rooms for the most part. So if you need this product, you've got to have it in the room that you're using it. And if that room is being used by a non-robotic surgeon to do a non-robotic case, then that is a dead sunk cost. The traditional endo-eye system, the 3D system, it's on a tower. It's mobile. It moves throughout the ORs. It allows tactile feedback. The major drawback is the wristing, which I would argue you can work through. Okay, so most systems in the hospital, if you have an Olympus tower, you either have a 180 or a 190 processor. They are upgradable, so you don't have to buy a whole new system. I think it's important. Olympus feels very strongly about adding to a system, not completely changing the system. You know, if we're sticking on the same robotics topic, if you have a Da Vinci S, it does not work with the SI products. If you have an S, you got to get the SI if you want the newest. If you have an SI and you want the XI, you've got to get a new XI. There is no adding to a system. It's completely swapping out and buying the whole new system. And clearly there's, you know, cost changes if you give back a system, but the bottom line is each one is a separate standalone system, unlike the Olympus process where you can add to what you already have. So costs are higher. Indications for robotics are minimally different. And the majority of the advantages of the robotic system are mitigated by the Olympus 3D system. So these are just more slides about what I've seen, you know, real life situation. This is our hospital. Like I said, to the right of here is University of Maryland. To the left of here is Johns Hopkins. We're right in the middle. When April 2013 is when we got the Olympus 3D system. We were the first system in all of North America. We were the third system sold in the whole world, and we were the first clinically used system. The first two were in Tokyo universities that weren't being used on patients. At that point, we were a very large GYN oncology multi-state referral practice, so the name was already out there. At the time, we had the highest volume robotic surgeon in the country, so we are a big robotic system. We were the first GYN epicenter for oncology in the country for robotics, and our benign GYN system was regional. We had just created an endometriosis center, center of excellence. So we wanted to start increasing our practice for the complex benign GYN systems. This was that picture we showed earlier. Mostly regional, you know. Most doctors would be very happy to be a Maryland doctor, but having Pennsylvania, Delaware, Virginia as your referral basin. So we initially purchased 2 towers and 6 scopes. The rest of it I had previously mentioned. We started doing the Google AdWords. Olympus is kind enough or helpful enough to produce a media kit that allows you to kind of increase your blast of the local market for print, for audio, for radio and video, so that you can kind of get the word out there about the 3D system as a non-robotic, three-dimensional process by which we can go through, the surgeries. And the websites were quite helpful. I think the Google words and all those tagline issues that are out there right now were amazing. And I think in our hospital, they were very fluent in the media marketing process. They were very savvy. We made sure that we come to the top when all the Google searches for endometriosis and all the particular keywords come. And I think for that, that's certainly part of the process. But without the surgeons, without the procedures, without the technology that differentiates us from other people, we wouldn't get the kind of results that allows us to have virtually a national referral base. So this is what we are right now. We've got patients from almost 50% of the states, all up and down the eastern seaboard, Midwest, few in the far west. I had a patient come from Dallas, Texas 3 weeks ago. She came in for her consult. She went home. She came back a week later. So, flew in on Tuesday, operated on Wednesday, stayed one night, and went back on a Friday morning. So we really kind of made this as easy as possible for these patients to come in. And these are some data. There's some data points. So for the last 5 years, I looked at data, and we got the system in 2013. So for 2011, 12, and early parts of 13, the robotic hysterectomy numbers were high. We were able to really increase what we were doing. The numbers were low in 2011. We had a lot more laparoscopic hysterectomies in 2011. The big thing that happened there was the morcellation debacle. So we were doing a lot of supracervical hysterectomies with morcellation. That completely ran dry to almost nothing. So we had to transition to total lap hysterectomies. And at that point, it was an easier process to be done on the robot. So as the traditional supracervicals went away, the robotic TLHs increased. In 2013, when the Olympus 3D system came to Mercy, you can see that was the apex of the robot, and it's been downward ever since. You can see the volume of cases increases year over year. The spread between robotics and traditional laparoscopy increases. And this year, it's actually more than 1-to-1 robotic to TLH. On average, I do about 90 robotic hysterectomies a year, and the TLH version of this year, we're on pace to do 125 traditional TLHs. So more than 50% are done non-robotically at this point. Surgical volume on the robot stands to reason. Back in 2011, there were very few indications that I felt were necessary for the robot. As I at this point don't do endometriosis on the robot at all. In 2011, I was only doing hysterectomies. As the morcellation issue went away, it became an issue, we did more on the robot, and as we've gotten back into a situation where I feel much more comfortable doing non-robotic hysterectomies, it has fallen off. Still to this day, I don't do the endometriosis procedures robotically. And then, as you can see, the total laparoscopic surgery volume, not just hysterectomy, has increased exponentially since it started obviously before the 3D system came in. This is very likely due to the fact that we started the Endometriosis Center before we got the 3D system, so it was already starting to ramp up. We're upwards, just in my procedures alone, almost 250 just in traditional laparoscopy. And endometriosis, you can see, is a large percentage. So these are non-hysterectomy surgeries, but they are very similar in reimbursement, a little bit less in time often, certainly significantly less in cost, and the 3D system has really made us a national referral center for these type procedures. I get patients from all over the country for this. So this is my raw data. I've cut my robotic hysterectomies back by a quarter. I've increased my traditional lap hyst by 1,200%. Total laparoscopic surgeries over the last 3 years has gone up by 85%. That includes all coming, not just hysterectomy. And the endometriosis surgeries themselves have gone up by 58%. So, our ability to get patients coming to us, partly because of the 3D system, they come in talking about the non-robot system, the blue light system, which is something called narrowband imaging. These are the reasons that the patients are doing self-referrals. These are huge. Within the hour before our webinar, I had 3 endometriosis referrals just in this last hour. All 3 of them were self-referrals, not physician-driven referrals. So they're using the internet. They're using, traditional media. They're using Facebook with these Facebook forums where they're being referred by their friends to see Dr. Alden because he does something different. These are things that were not as prevalent 3 to 4 years ago. I can easily identify something that makes me a market leader and a differentiator amongst the other doctors in the city. And as I pointed out, this is a big city and a difficult city to be a differentiator when you have Johns Hopkins or University of Maryland in your backyard. So the data is clear. This is helpful. It drives patients to your hospital. It's universal. It's able to be used by urology, colorectal, GYN, general surgery. So it's not just specific to GYN. And it's one way to push more and more procedures off of the robotics platform, which no one argues, or very few argue, is cost neutral, and very likely in most situations it can be cost prohibitive. We've already gone over these. Are there any questions out there?
Thank you, Dr. Odland, for that great presentation. We'll now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. Additionally, we have Corinne Mauser, Senior 3D Manager from Olympus, here to answer any product questions. Let's see, our first question coming in from the audience is, I was surprised on the slide that showed the gaps in surgeon training. Is this why so many need the robot? Would 3D help solve this?
Yes, in all honesty, that was the main driving force behind Intuitive and their ability to convince a lot of hospitals to buy multi-million-dollar robots, because it was allowing their surgeons to transition patients from open surgery to minimally invasive surgery. There's clear advantages with prostatectomies and radical prostate surgeries, which was the initial indication, and gynecology came behind. And as we said, I mean, there are certain patients that would have gotten open cancer surgeries that now don't. So there is a significant improvement in quality of life, and that was before the Olympus system came into power or came into being. And absolutely, the Olympus system fits all the same footprints that the robot does at a fraction of the cost.
Wonderful. Thank you for that. Another question from an audience member says, my surgeons have to be credentialed to use the robot. Do they need this to use the 3D system?
Do they need credentialing, do you think? Is that what the question probably is? In our situation, no. I mean, it's a traditional laparoscopy. And in fact, if the surgeons don't feel comfortable with the 3D, you can actually turn off the 3D. You can make it a traditional two-dimensional laparoscope. You still get the advantages of the crystal picture of the 10-millimeter image and also the flexibility of the scope, but you don't have to have 3D. So in that sense, my hospital does not credential and doesn't feel the need to, because the difficulty with robotics and the learning curve with robotics is how to manage the robot. You're using your feet to move the camera in and out. You're using your feet to toggle between monopolar and bipolar energy, and you're using your hands to mimic the wristing options. And those are all things that are not, sorry for the pun, they're not intuitive, so you need to learn that. If you're a laparoscopist, you already have all the skills for the 3D, you just have better visions. There's no need to have credentialing.
Great, thank you, Dr. Odland. Another audience member asks, for procedures where the robotic has been found to be advantageous, like radical prostatectomy and colectomy, does the Olympus 3D provide the same type of results?
I can't speak for the radical prostate, to be perfectly honest with you, but I know for a fact that the advantages for colon surgery has been mitigated. I have a good friend who initially poo-pooed the idea of three-dimensional laparoscopy until he started doing cases with me for the horrible endometriosis patients that did require bowel resections. And after he spent maybe a good 6 months working with me on these, we ended up getting a third 3D tower specifically for him for his cases that didn't include me, which included all of his hemicolectomies, even his gallbladders and appendixes. He feels more comfortable letting the residents being in charge with this system because they can see the cystic duct, the common bile duct, the appendiceal artery, all these kind of smaller, more difficult things to identify more clearly. So we actually added a tower for general surgery purely for those kind of situations.
Wonderful, thank you. Another question asks, how much does a 3D system compare to 2D, and what is maintenance on the cameras? Have your cameras been out for frequent repairs? So
with the third tower, we actually bought 10. So we have 10 now. We started with 6, we went to 10. There's never been a time where I couldn't use 3D because I did not have the availability of a camera. I traditionally do 5 to 6 cases a day, and there are 3 of us doctors that use the cameras on any given Wednesday. There are times when 1 or 2 goes out. To be honest with you, I don't know it because there's always more than enough. And there was anything more to that question? Oh, maintenance costs. I think maintenance costs is minimal. Clearly, the maintenance cost of the robot is what, 10% of the initial cost, so it's $200,000 to $250,000 per year for a maintenance fee. Even if the Olympus systems maintenance fee is a similar cost, we're talking, $10,000 to $15,000 per year in maintenance. So a minimal amount. In fact, you can argue that 1 to 2 towers for Olympus is the cost of the maintenance contract for the robot. So it's a no-brainer in that scenario.
Great, thank you for clarifying that. Another attendee is asking, what process did you use to convince the surgeons there were disadvantages for using the robot?
Just through use. I found that a lot of docs, especially general surgeons, they don't think they need the 3-dimensional system because they're good at doing traditional laparoscopy, or the other side of that coin is they feel safe with the robotic system, but when they use it, it's kind of like driving an expensive car. You can't explain how good it feels until you let them kind of get a hold of it and see how well it drives. The robotic guys realize that a lot of their insecurity that maintains their pull on the robot is gone with the 3D system. That they don't have the issues they had with traditional laparoscopy. Whereas the other side of that coin, the surgeons that think they're good enough with 2D laparoscopy, and I'm sure they are, they just realize that they're actually better with 3D, and that's honestly what I was. I thought I was good enough with traditional laparoscopy, but in all honesty, I'm a better surgeon today than I was 3 years ago, and I'm comfortable saying that the system helped me become that better doctor. It's not just me.
Wonderful, thank you. Another person is asking, I'm also surprised at your comments about resident fellow training. Most academic medical centers do have a secondary robotic console, which does allow for this education and training. For some procedures, the robotic approach is the gold standard. What other training methods do you recommend?
So in our system, we have 1 system. So we have 3 total, and 1 of the 3 has the secondary, and then the other 2 don't. So depending on which service has the secondary console, they're basically the only ones that allow their residents or fellows on. I have a minimally invasive fellowship, so I do have the docs with me. When we get the multi unit robot, they are on there with me, and they do tend to run the show. But otherwise, it's a 2-year fellowship for me. So we're 5 months into the fellowship now. I'm not to the point where I feel comfortable letting my fellows do the entire case by themselves. So at this point, they're still getting used to the wristing motion, doing the suture closure, because the cuff closure, since there's very little likelihood they can cause trouble with that. So I'm getting them used to the process of using the robot without having them do significantly difficult, complex maneuvers. There's also a training module on the robot where they can use the robot with a simulator. The traditional laparoscopy, we've got the ability to use the laparoscopic trainers. They can take the lap trainers home with them. They can practice suturing. They can practice transitioning from one hand to the other. And although they're doing that in 2-dimensional laparoscopy, if they can get the basic rudimentary moves down traditionally, then when they come back to the 3D system, they're more refined. So I find just through sheer repetition, all of this improves, be it robotic or traditional laparoscopy.
Thank you. That's helpful to understand. Another attendee is asking, what challenges did you encounter making the change from robotic procedures to laparoscopic procedures?
So I was the exact opposite. I trained in an MIS, a minimally invasive surgical fellowship, in 2006. We didn't get the robot till 2009, so the majority of my laparoscopic basics were done laparoscopically. So we resisted the robot because we didn't think we needed it. So a lot of doctors went the exact opposite. They were open doctors that went robotically. So to them, they learned the laparoscopic view robotically. So their learning curve was high. For me, my learning curve was, how do I use the robot efficiently? How do I learn to keep things in view? How do I learn to use the foot pedals? How do I safely learn to toggle amongst monopolar, bipolar, cut versus coag? These are all things that are very specific to the robot, not to laparoscopic surgery. So my transition surgically was easy, but the learning curve of the robot was still there, absolutely.
Wonderful. It looks like we just have a little bit of time, so we'll have one more question. Our last one today is, you said you received new referrals from all over the country. What do you think led to those?
Honestly, I think the biggest thing is the word of mouth among young women with a very debilitating disease. And if you are able to take care of them in a way where they feel like they weren't taken care of before, in this situation, validate their pain, take care of their pain surgically, and give them a new lease on life, they are willing to speak from the mountaintops. And the mountaintops are honestly Facebook and Google websites and chat rooms and blogs. And what delineated my care from a lot of the other doctors' care was, I had a three-dimensional laparoscopic system that wasn't robotic, because they've been told about the monopolar energy use with the robot and the lack of tactile feedback, and that my ability to use the three-dimensional laparoscopy without those two major issues was a draw, and my ability and willingness to do very, very complex dissections and resections was the reason why people feel that it is worthwhile. The majority of doctors that do what I do charge cash. They do fee for service. So you're getting $20,000 to $40,000, in hospital costs and physician fees. Unfortunately, because they know that very few of us do it, and if you've got a 20-year-old daughter that's in pain, you'll do almost anything to get her out of pain. So people are willing to spend the cost to get on an airplane and pay out-of-network insurance fees for a guy that takes insurance for the same exact thing, and I think that's part of it.
Very interesting. Thank you. It looks like that's all the time we have for today. I want to thank Dr. Odland for his excellent presentation, and to our audience members for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Awesome.